I'm Dr. Benjamin Fergus, and I'm the founder of Grip Approach. We get a lot of questions from attendees of our courses and potential attendees of our courses, and one that comes in very frequently is from our clinical attendees. And the question is, how and when should they incorporate the Grip Approach method of evaluation and treatment into their practice? And it's a great question. In fact, when I was developing this approach, it was sort of out of frustration with not having a very accurate system of applying therapies, evaluations, and other rehab methods into a cohesive system that worked for patients. And we've taken a lot of care to develop that within Grip Approach. So when I see a new patient for evaluation, there's standard things that we need to get through. Every patient deserves a neurological examination that's either local or global based on their presentation. So we do a pretty thorough check of cranial nerves, upper extremity exam, lower extremity exam, etc. We'll also clear out the objective findings of orthopedic tests and look for trends in the positive test to narrow down on a few possibilities. Most orthopedic tests are not diagnostic in of themselves. They lead you towards a category of presentations that may be possible, but it's still very valuable information to gather for a before and after, and it's very good for documenting and sharing that information with other physicians. Once we've passed through our vitals, our neuro, and our orthopedic evaluations, I need to see my patient move. And we typically start with a simple question. What activities or movements are you having difficulty generating? Now, that switches the conversation some from what's painful, why is it painful, how is it painful, and when. It instead says, do a task that you're having trouble doing. Now, they may have trouble doing that task because they're limited by pain. That may be the case. But often there's a high amount of fear avoidance or some difficulty generated emotion based on joint complex interference, muscle issue, some biomechanical elements, and we can really see the full picture of what's possible for them in simple movements. In my office, I use a gait analysis evaluation as a standard test. We want to see, can they walk down the hallway and back? If they do that without a problem, we go to single leg stance and have them get up out of a chair and sit back down again. And we start to really paint a picture about the basic movements. If this is a higher level athlete, I'll also have them lift some weights or throw a ball or do some of their athletic tasks to get a general feel for what movements are comfortable for them and where they may struggle. At that point, I've started to narrow down my grip evaluation to NZR1 or NZR4, shoulder complex, elbow, etc. And I try to get a couple categories to look at. And in those categories, I will evaluate around the joint. A good example would be the hip. If I have a patient that comes in that's having issue generating movement in their low back, in gait and squatting, I'm going to look at the hip in all three planes of motion. Those tests will only take you a few moments. Same thing for the shoulder, upper extremity and neck issues. We need to rule out these limitations at the shoulder in order to set up a framework for success for those patients. So that grip evaluation comes in towards the last third of my exam. And as I go through the motion, I try to see trends in the test. Do each movement that they have trouble with have a corresponding EFROM that's involved and limited? Hip antimotion is a good example. Anytime a patient goes into a deep squat or a sprint or a forward kick, they're going to need adequate amounts of hip antimotion. And if that's limited, we will see the body kind of collapse and lose control at a certain point in each movement. So if we can take one EFROM test and tie it to 3 of their movements that are limited, you have a really good starting point for where to generate your treatment approaches. So this is a little summary of where and why we put Grip Approach evaluation where we do. When it comes to treatment methods, we try to base things on first exercise. If we perform a global reset, does that individual regain their capacity for moving in the way that they were originally limited? If they can, that's what they're going to work on at home, and they're going to do that pretty frequently. Sometimes up to 15 minutes total per day will be focused on a single global reset strategy until the brain is in control of the body again. If that global reset alone is not effective, we may need to look at the TSI location. The TSIs look for vectors of muscle pull where they intersect on the anatomy to help you generate a specific movement in a single plane of motion. And there's been several nice studies that look at stimulation of those points as helping the motor control from the brain to the body generate those motions again. The goal of that treatment is liquefaction of the area, but we can also think of it as a different form of stimulus for the nervous system. If we need to treat the tissues in that way, I typically recommend that we do that twice a week for a total of 6 to 8 sessions, and that's done in conjunction with the home exercise of the global resets. A typical treatment plan with grip approach methods for a single problem is between 6 and 10 sessions to discharge. I hope this was useful information for you, and we'll record a few more videos of little tidbits of how you can kind of incorporate this into your practice more effectively. Thank you.